Thank you. Thank you, the panel, panelists and all the postgraduates and the moderator for this wonderful session. I have a short secretary report to share. Okay. So I think we have to congratulate the entire Salem team, Dr. Shivshankar Subramaniam and the entire organizing team at Salem for the successful conduct of our first annual, for our first meeting, that's the annual conference at ERCAT, went off very well. And there was a separate postgraduate session followed by the main conference. We had about 200 registrations and close to about 50 abstracts which were presented. And it was a wonderful 2.5 days of academic feast. So I personally thank on the behalf of TNISG all the organizing team for conducting this conference. We have also placed on bid bid from Tamil Nadu ISD to host the next year's ISG Con. Today only we have been able to submit it. Now the main ISD Secretary Office will shortlist the cities and then possibly send it across for voting. So if it comes down to voting, I'll request all the members who have registered with the national body to kindly vote for TNISG. And those members who have not become members of the national body, please do become members, because we have about 430 members in the state, but of which only about 200 odd are national members from what I know last year. So there are about 200 odd members who have not yet become, so I request all of you to become national members so that we will be able to represent ourselves better. And the next 10th ECME, it's mainly focused on the postgraduates so that we give an opportunity for postgraduates who are not in Chennai, who are not residing in Chennai, people who are in centers out of Chennai to present. It will be a couple of case presentations followed by a guest lecture by a esteemed faculty. So this will be from Tirunelveli Medical College. Please note the date, it will be on 20th March. Usually it is a 1 hour session between 7 to 8 p.m. So further program schedule will follow. And I take the opportunity to congratulate Dr. Sindhuja from ICH Egmore. She was one of the first last year's postgraduate TNISG postgraduate travel grant awardee. She had presented her work at on IBD at Italy, and for that I welcome her and request Madam to Dr. Jayanti to kindly hand over the prize to her. It's a check for 1 lakh, and I congratulate her, and we wish to see her. Come on. Good. Next is welcome Dr. Amrita Varshini from CMC Vellore, who has presented a work, who was also this year's TNISG Postgraduate Travel Grant Awardee. So come over and request Dr. Rajnikant to please come over and hand over the check for the place. And I request all people who have gained this. There is a request for both the awardees. I want you to write it out as a review or submit your own original article to GHEP. So it will be good for publication. A good review article of your research work will be of use to us also. Thank you. Okay. So that's right. And the research project that is ongoing now is a HCC study. It is still in the data collection phase from 17 centers across Tamil Nadu, and the data collection will end in 31st of March 2026, and subsequently it will be analyzed, and hopefully we will be having a manuscript by the middle of this year. And there is one more next proposed TNISG research project. The topic will be about objective phenotyping of symptom-defined GERD, a multi-center study from South India. The aim will be to determine the proportion of patients who have symptoms, who are positive in the symptom-based index, where we look for objective evidence of GERD with either endoscopy or ambulatory reflex. The principal investigator will be Dr. Ilavarsi. The protocol is still being reviewed. Once finalized, an email invitation will be sent to all centers who have the capacity to do both endoscopy and manometry and the pH studies also. So I think further discussion will be going on in the next 1 or 2 months, a core committee to be formed and finalized. So that's where it is. And the Crohn's and Colitis Foundation of India has requested 3 states to initially start off the state chapters. One is Chandigarh, other is Kerala, and the third is from Tamil Nadu. So the inaugural meeting, at least to start off as an inaugural meeting, will be held on 29th of March at the same hotel tentatively from 9 a.m. to 1:30 p.m. Conveners are Dr. K.R. Palniswamy and Dr. Amit Datta. The invitation program schedule will follow probably in the next week or 10 days. So please mark the dates. It will be on 29th March from 9 to 1:30. It's just an inaugural meeting. Subsequently, how to become members, what will be the office bearers, and everything will be shared later on. And one more request to the new trainees, so DNB trainees and DM trainees, request all of you to become student members of Tamil Nadu ISG. Fill up the online application form and submit the fees. It's available online, and the student membership number will be sent to you by the end of this March. And henceforth, we will require you to quote your student membership number to take part in all academic activities. And please also enroll as member of the national body so that you will be able to take part in ISG, national body meetings that you have every year. And please scan your attendance for us to meetings. With that, I will be all move on to the CME part. I request the chairpersons and Dr. Prem Kumar and Dr. Preeti, who will be joining us shortly, to take over and conduct the proceedings, please.
Good evening all. Now we move on to the CME program, where I call upon Dr. Sangameshwaran, consultant Apollo Hospitals Managaram, to talk on green endoscopy. Is it curtain rise for single-use devices?
Good evening all. At the outset, let me thank the TSG committee to TNISG for giving me an opportunity to speak about green endoscopy. Is it a curtain for single-use devices? Why this topic? When I think some 20 days back I got a call from Paramanayam sir and Arul Prakash sir. I was very hesitant. What is this? I really don't know. I was really hesitant. எனக்கு சார் நான் ஏதாவது தப்பாக நிறுத்திடுங்க சார் அப்படிங்கிற லெவலில் தான் பேசிட்டு இருந்தேன் சார்கிட்ட. ஓகே. So then I got confused. Then I started going through the internet. What is green endoscopy? So all started from what we all know, but let me explain it again. It all starts with greenhouse gases. Greenhouse gases are components of the Earth's atmosphere that absorb the infrared radiation and re-radiate it in all the directions towards the surface. So who are all the top greenhouse gas emitters in the world? According to 2023 data, China stands first, second is United States, third is India. You can see European Union is very low. So the greenhouse gases are components of the atmosphere, both natural and anthropogenic. Anthropogenic means man-made, that absorb and trap infrared heat emitted from the Earth's surface. These gases, like I will be coming back to that, they allow sunlight to pass through the Earth but trap the heat radiating backward. Impact is elevated concentrations due to human activity, which in fact again due to burning fossil fuels, deforestation, which drive the global warming and climate change. So what are the greenhouse gases? The major greenhouse gases are carbon dioxide, methane, nitrous oxide, fluorinated gases and water vapor. Because of these greenhouse gases, the Earth's core temperature, which should have been roughly minus 18 degrees Celsius, is currently around 15 to 17 degrees Celsius. So the greenhouse effect increases as humans emit more greenhouse gases. So what are the effects? Some heat escapes into space, some greenhouse gases retain the sun's heat in the Earth's atmosphere. The Earth's atmosphere reflects some heat into the space. Human enhanced greenhouse effect, this is the most problematic. Less heat escapes into space, more gases retain heat in the Earth's atmosphere. So what is carbon footprint? Carbon footprint is the total amount of greenhouse gases, including carbon dioxide and methane, produced by human actions such as burning fossil fuels, which is again done for producing electricity heating and transportation. It is measured in tons of CO2 equivalent. The key components are primarily CO2. It also includes other gases like methane and nitrous oxide. It includes direct emissions and indirect emissions. The average global average footprint is around 4 tons per person. In United States alone, it is significantly higher at approximately 16 to 17 tons per person. It can be divided into 3 scopes like carbon footprinting. The scope 1 includes generated emissions, that is gas heating or fuel oil burnt on site. Let it be a company, let it be an hospital, let it be any establishment. The generated emissions are gas heating or fuel oil burnt on site, fuel used in company vehicles, refrigerant, losses from air conditioning fridges, emissions from manufacturing process. Purchased emissions, that means electricity purchased from energy providers. It's not provided on site, not produced on site. Electricity for electric vehicles, steam, heat or cooling, that is generated off site. Indirect emissions includes around 15 categories: goods and services, distribution and use of goods, waste disposal, employee commuting and business travel. This employee commuting accounts for more than 50% of the carbon footprint. So, how to calculate carbon footprint? Carbon footprints are typically calculated over a year to measure an individual's or organization's impact. Online calculators are available which takes into account household use, energy, driving habits, diet and travel, with emissions often expressed as CO2 equivalents. So, this is the formula I found out. This online formula is there. We can get that. If you provide the data, it will give in carbon equivalent. So, this again the same formula in a different form. The impact of climate change on human health: global impact, weather impact and health impact. Global impact, we can see, we all know, more extreme weather, rising sea levels, increasing CO2 levels and rising temperatures. Weather impact is more of pollution, poor water quality, environmental degradation, extreme heat, severe extremes of weather. And health impact, lot of health diseases are connected to this, including infections, and now I think malignancy is well connected to all these things. And the major consequences of the greenhouse effect are: it causes more frequent or intense extreme weather events, exacerbates or precipitates extreme, making wet regions more wetter and dry regions more drier. It raises the sea levels due to melting of ice and glaciers. It alters the ecosystems. So, carbon footprint of health care. The data from US states that more than 5.9 million tons of waste are produced by hospitals per year. It is the second largest contributor to landfill waste after the food industry, and it contributes around 10% of the global green gas emissions produced by hospitals, and 33% of the total hospital waste comes from operation theatre. So, this again a study from Geneva. This we can see how much is the carbon footprint from health industry. So, 5.2% of the total greenhouse gases are produced by health sector. What does this mean? If global healthcare sector were a country, imagine this provided by from a individual country, it would have been the 5th largest emitter on the planet. So, the top contributing departments or specialties in hospital to this carbon footprint are: the first and most important is operation theatre. The next comes ICU. What will be the third? It was really surprising for me. Third is endoscopy room. This unit typically ranks third in the hospital waste generation. So, this is our typical endoscopy table. We can see these are all things which contribute to carbon footprint. My flow of discussion henceforth will be about green endoscopy, carbon footprint of gastrointestinal endoscopy, especially low value endoscopy, single use accessories, single use endoscopes, difficulties and challenges in establishing green endoscopy, use of digital tools or artificial intelligence in green endoscopy, innovative low carbon footprint accessories, scheduling diagnostic and therapeutic endoscopy sessions, bidirectional endoscopy, and the society consensus statements and guidelines. This slide shows a prospective study of carbon footprint from routine GI endoscopy. A total of 450 scopies, both upper GI and lower GI, were examined. We can see 100 procedures of each of these contribute to 219 kilograms of landfill waste, which is equivalent to water waste of 1385 gallons, energy consumption of 1980 kilowatt hour. If we extrapolate in a different way, it's like traveling for 1200 miles. And auditing of these items used in the procedure, 20% are potentially recyclable. We can see upper GI endoscopy, the carbon footprint is around 5.43 kgs, and colonoscopy is around 6.71 kgs of carbon footprint. Low value upper GI and low value GI endoscopy procedures, that means not with a strong indication. That means the low value, what does that mean is not a strong indication exists to do that endoscopy. Each year low value scopies emit around 4133 tons of carbon dioxide, which is equivalent to 17 almost 1 crore 76 lakhs liters of gasoline, that is petrol. So carbon footprinting and environmental impact of gastrointestinal endoscopy procedures was studied by AIG in a prospective multidimensional assessment. What they found out is carbon footprinting, like the patient travel, that's what I was stressing upon. Patient travel contributes around 83%, remaining all other things only 17%. So the carbon cost of inappropriate endoscopy, it's around 45 per 1000 prescribed endoscopic procedures per year, which is again around in that 15 per 1000 seems to be inappropriate in a study. So green, from this the concept of green endoscopy was derived. It's a sustainable approach to gastroenterology designed to minimize the environmental impact of procedures, specifically the carbon footprint and waste, without compromising the patient care. So impact of single use endoscopes, the left side we can see it's green. So it reduces, we all know it was invented for reducing risk of infection. There is absolutely no disinfection and reprocessing. It should be thrown away after the procedure. But the downside of this is the production emits more carbon dioxide, and carbon dioxide during transportation of the instruments, and increased landfill due to its disposable, and increased financial burden. Even Boston has studied their spyglass DS cholangioscope impact of on greenhouse gas emissions per patient year. They have calculated if the patient, like without spyglass, the procedure is done, or with spyglass, they tell that 6.4 kg only production of CO2 waste is there from which they use spyglass, because how it extrapolates is because completion of the scopy on the same day, same sitting. So what are all the interventions or outputs and methodology to go about with green endoscopy? The main interventions are reusables, with judicious understanding of reusables, and digital tools, water efficiency and lower emissions, and it can lead to reduced waste product and we can reduce the water usability also. How this can be achieved? It can be achieved with reducing inappropriate endoscopies, repeat procedures, and reducing energy utilization, and reducing the use of single use scopes. And what can be reused is endoscopy caps and trays, rechargeable batteries, lifting solution and dies. What can be recycled is segregation of waste products, waste management, training for healthcare workers. Ongoing research by it should be in a greater society level, which integrates the industry support also. So growing green pre-procedural, we can ask, we can do a telemedicine consultation instead of the patient coming to our office for consultation, and we can prefer non-invasive alternatives like FIT, capsule testing, and electronic communication, electronic documentation, and prioritize high yield procedures. During the procedure, assess carbon footprint of each procedure, judicious use of instruments, appropriate waste disposal, and thoughtful use of PPE. Post procedure, paperless digital communication, environmental cleaning kits, virtual patient follow-up visits, and energy efficient smart devices in endoscopy and pathology units. That means instead of using the regular lights, we can prefer LED lights, things like that. And this slide shows holistic approach to green endoscopy. We can judiciously reuse, sterilize, disinfect with the help of technological advancements and the cost considerations, and patient safe without compromising upon the patient safety. So reuse endoscope, some things can be reused. What can it, with the safety and sustainability, some things can be partially disposable and some things are single use. So as an endoscopist, we must minimize unindicated procedures, adhere to reprocessing protocols, judicious use of accessories, and ongoing research and education needed to understand this. This shows gastrointestinal how NBA uses helps in this reducing carbon footprint. We can see this slide, and study shows if you use all gym staging and e.g. gym staging for intestinal metaplasia using NBA instead of using dye or biopsy, we can reduce the carbon footprint and without compromising much on accuracy. So innovations in endoscopic technology like higher zoom levels provided by the forerunners of endoscopy, nowadays they have gone up to 120, 140x zoom. It's all optical zoom, not digital zoom. And endocytoscope, artificial intelligence use of lesion detection, virtual chromoendoscopy, there are NBA, BCA, LCA, iScan and RDX. Non-endoscopic alternatives, it's a solution for low value GI endoscopy like FIT, fecal calprotectin. Instead of regularly using sigmoidoscopy or colonoscopy for assessment of IBD, we can prefer calprotectin, urea breath test and hydrogen breath test for malabsorption and dyspepsia. And with regard to polypectomy, this slide and shows that instead of the traditional strategy of hot snare polypectomy, we can prefer cold snare polypectomy for polyps less than 10 mm. There is now a new cornstarch eco-bowel being used in abroad. It's compostable within 12 weeks and its carbon neutral certification is there for this. And our Ambu, we know that Ambu bag, they are very pioneers in disposable endoscopes. They have designed a bioplastic handle and the entire all wheels are bioplastic only, world's first endoscope with bioplastic handles. What are the difficulties in establishing green endoscopy? It's a knowledge gap. Before this topic I didn't know anything about green endoscopy. It was totally that we should not compromise upon the quality and it needs regulatory requirements. There is a lack of incentives for this area. So we need incentives further to do more research on this topic, and financial impacts are there. And ESG's green ladder, it contains 7 to 8 steps. The first step is create an opportunity, join forces, create a vision, communicate a vision, understand, we will be facing new challenges, but through facing that challenges only we will thrive and sustain. The 5 R's of greener endoscopy are reduce, reuse, recycle, research, rethink. Coming to the conclusion, the sustainability in endoscopy for green endoscopy is like it's a taxonomy. It should start with the individual level, then unit level, hospital, regional, national and international level. The short term goals are choose green preferable purchasing strategies, establishment of recycling waste strategies, improvement of adequacy and appropriateness. Medium-term goals are inclusion of sustainability by the industry, implementation of alternative test to J endoscopy, incorporate sustainability endoscopy curriculum. Long-term goals are remodeling of the endoscopy structure units, shift towards reusable versus oligo-use accessories, industry public disclosure of the economy of these products. So, reduce low-value procedures, usage of instruments and supplies, reduce pathology specimen jars, reduce expired products, reduce sedation resources, reduce paper usage, reduce supplies used by the patient. Nowadays they have advocated like they can use, hospitals can go for establishment of windmills for procurement of electricity. It's one of the eco-friendly initiative, and implanting solar panels over the car parking regions or the walls or the rooftops can also help. And this is a Boston hospital, Boston Medical Center. You can see they use their rooftops for microgreen harvesting. And coming to closing remarks, this I extrapolated this to ICE engine versus ICE engine cars to a EV car. If we use an EV car, the energy waste is around only 5%. 95% we can drive. The energy is used for driving only. If we use a ICE engine car, it's 80% of the energy waste, only 20% used for driving. On this note, I think I also changed. 2016 is my car, and 2026 I recently got a EV car.
It is called greenwashing. They produce a battery, they use so much, they produce greenhouse gases, and the production of
That was a controversy.
and we don't know how much
Impact it will be.
and disposing battery. It's called
It's still
and they promote saying that it is green energy. It's called greenwashing. There is a company that they say we are green efficient, but it is not.
disposal of the battery.
Production, how do they produce?
Even disposing is also a problem. Afterwards, the life cycle, what they will use to do.
That means emissions are far lesser, sir. If we can.
At least in the city.
Yeah, definitely.
It is produced in China and supplied to America. So America's
Latin American
carbon production is less. China, you see, there is
So when I was going through this invitation, I just found out TNISG is also a forerunner in green endoscopy. You can see they have used a green background and logo also is in green. Okay. So E-asset is the real asset, inheritance for future generations. So we all should understand that importance of environmental conservation, and thank you.
So I have a question for PGs. What is green hydrogen? Anybody? What is green hydrogen? Green hydrogen is hydrogen where it is not green. All hydrogen are same. In the production of hydrogen, it is less carbon dioxide is produced. So it's called green hydrogen.
We are paperless. We are not fully paperless. OP plus OP, both are electronic. So you can't say it's electronic. Because medicines you can't write only electronic. So already started you write all things.
Pirama,
We are in the track.
when we were students, we used to hold the patient's bite guard and all without gloves only. And in fact, when we use glove, our professor used to shout, previously we weren't using glove, why you are? So after that, after passing, we were washing and using the glove. Can we do that? It is much easier. So much gloves are going in a single every case. Why not we wash the gloves and reuse it? we are anyway washing the endoscope with so many internal channel.
So this topic was mainly for that. So on one hand, we moved from to use single-use devices because we are worried about infection during endoscopy, infection with procedures and all that. Now the cycle is coming again a full turn where we are looking at the environmental impacts and trying to see whether we can reuse accessories, whether we can come down on all these, the gloves that we use, for example, whatever euros. So the thing is, probably we are again running the same cycle again all over, but with a different perspective. But how far it is manageable in this current scenario, where we know that there are, 10 years earlier we had endemic of duodenoscope associated infections. So whole hospital, all GI endoscopy journals would be carrying multiple papers which will say, okay, this is, and then there was a move towards the single-use devices. Now we are moving the other way around. So I think that is what I want Sangameshwaran to come around to.
There now is anyway we are reusing plates, cups, these are all reused.
One thing, what you can do is when you are doing a gastro and colon together for a patient, you can use the same glove. You don't have to change gloves for that. You do gastro and colon the same. One simple thing. Yeah, of course, first gastro.
Just one interesting thing though, I mean, looking at carbon footprint of all this, and we're talking about e-paper and electronic, but there are studies to show the amount of carbon dioxide emitted from computers, running computers and software. So it's very difficult compromise to make actually, just going e-based.
We are finding alternatives, but that alternative also is
Like Dr. Ravi says, you say e-vehicle, but you know what all is happening behind the production of e-vehicle batteries. Similarly, there are a lot of articles about computerization, which is also causing carbon. It's very difficult balance to make.
Much easier if you take everything to space and store all data and store. They are trying to look, but only thing is that if something happens to the computer there, they cannot repair it.
So, thank you, Dr. Sangameshwaran, for
thank you, sir.
probably
Thank you.
kindling the interest on green endoscopy. I'm sure he took a class on physics or chemistry, I don't know, first, and then he went on to endoscopy. Then I will call upon next speaker, Dr. Raghavendra, to talk on quality indicators in endoscopy, Indian perspective. Over to Raghavendra.
Thank you, sir. Good evening, everybody. Today's my topic is on quality indicators in endoscopy, the Indian perspective. I bring warm greetings from Southern Railway Hospital, Perambur. So when Dr. Perama sir approached me 1 week back, I thought I was the only person, but Dr. Sangameshwaran also cleared the air. So we're sailing in the same boat. So when I began preparing for this session, I realized how deeply these quality parameters can be integrated into our routine endoscopy practice. So today I will try to my best to simplify these concepts and try to integrate these quality indicators into our practice so that it makes a difference for our patients. And after all, that is all what we aim for when we try to improve the quality indicators. So my outline of the talk will be, I'll be explaining a few concepts and definitions, and then talk about the quality indicators which are common for all endoscopic procedures. A little bit of quality indicators with pertaining to the various gastroenterological procedures, the global philosophies, and how we can adapt to our system. So let me begin with a simple case. 52-year-old gentleman. We commonly come across such patients in our clinical practice. He is come to you for a routine sclerine colonoscopy. He doesn't have any symptoms. There are no family history of colorectal cancers. You do a colonoscopy, fairly normal, okay colonoscopy, you do it and you report it as a normal study. 1 year later, again the patient comes back to you. This time he presents with a rectal bleed. You again go and do a colonoscopy. This time you see a lesion, 2.5 centimeter, probably cancerous lesion. So you go back and review your images. Probably the difference between that polyp and cancer was not the equipment, it was not the experience of the endoscopist or not the intelligence. It was some of the smallest things, probably the quality indicators which we are going to talk about in this discussion, that we do in practice that makes a huge difference in the patient's lives. So what is quality in endoscopy? Quality in healthcare is the degree to which health services for individuals and populations increase the likelihood of a desired outcome. In endoscopic terms, a high quality procedure is one where which is clearly indicated, where you made the where you have included the relevant diagnosis and you have excluded the unwanted ones, and you treat the patient with any therapy that is deemed appropriate and effective, and keep the harm to the patient to the minimalist possible extent. So towards this ideal, quality indicators have been developed to compare the performance of an individual or a group of individuals, creating benchmarks. So it's a continuous improvement model. It's not just one time. It is like, it's not about perfection, it's about measurable consistency. So why does it matter, these quality indicators? We always have had some uncomfortable encounters with our patients. Maybe you would have thought to give an NSAID before an ERCP. Patient lands up with after a normal ERCP with post-ERCP pancreatitis, or you would have liked to treat the patient for GI bleed, but then you deferred at that point of time, and then patient comes to you back with a rebleed. So sometimes we think that the process could have been somewhat different. So because what happens is, endoscopy per se is a very highly operator dependent procedure, and that is why exactly these quality indicators matter. If we do not measure the performance, we cannot improve the system. So coming to the types of quality indicators, basically quality indicators are three different types. One is the structural, wherein you get the infrastructure from the per se from the hospital or the equipment. The second one is the process indicators, that is exactly what we do during the procedure. For example, following certain protocols or classifications to tell how to guide us. And then the outcome indicators, which are what happens to the patient as a result of your the care which you have provided to the patient. The outcome measures or indicators are the most important ones, but in practice it's not always easy to measure the outcome indicators because of the large volume of data, and sometimes you will have to follow up these patients. So the process indicators are actually what we do during the procedures that actually act as a surrogate marker for the outcome interventions. So the quality framework, all the quality framework which the different guidelines discuss, is based upon three things. One is the pre-procedure quality indicators, intra-procedure, and the post-procedure quality indicators. This applies to the entire spectrum of all the interventional procedures which we do right from OGD to the various therapeutic procedures. Quality as such is not limited to what happens during insertion or withdrawal of a procedure. It begins just before the procedure. When you meet the procedure, you explain the patient what you're going to do, get the consent, explain the risk, assess the patient. All these things start right from when you do the procedure, before the procedure. And then it continues during the procedure with a complete proper examination and proper documentation. And also it extends after the procedure with complication monitoring and appropriate surveillance advice. So this table actually shows the quality indicators which are common to all the procedures, the pre-procedures, intra-procedures, and the post-procedure events. The yellow colored highlighted ones are like the procedures which include like consent, indication, proper sedation plan, prophylactic antibiotics, antithrombotic therapy, these things. During the procedures, photo documentation, patient monitoring, endoscopic specimen verification, and post procedure you start with the discharge instructions, patient instructions, and also follow-up recommendations and documentation of the adverse event procedures. What is more important are the green highlighted ones, which are called as the priority indicators. These are called as priority indicators because they have a favorable impact on the quality of care for these patients, and once they are measured, they help in setting up benchmarks. So I'll be discussing about the priority indicators for all the various procedures. Let me start with upper GI endoscopy. Upper GI endoscopy, as you all know, is a minimally invasive procedure, generally safe and well tolerated procedure. But at the same time, what happens in upper GI endoscopy is many studies have shown that around 5 to 50% of your upper GI endoscopies are without a proper indication. So you expose a patient to a procedure which has got some potential implications, and these can help, which can be harmful to the patient as well. So these are these tables show actually the various quality indicators in upper GI endoscopy. Again, pre-procedure, intra-procedure, and post-procedure quality indicators. I'll be discussing on the priority quality indicators for an endoscopy. First thing, priority quality endoscopy indicator is you should have appropriate indication. If not indicated, then at least you should document why it is being done. Another key important area is the photo documentation. Photo documentation, various guidelines recommend photo documentations from a minimum of 10 images to a maximum of around 22 images. These act as surrogate markers for a complete examination. Also, you have the various, as postgraduates, you must be knowing the various classification systems which we commonly use for reporting in endoscopy. The Los Angeles classification. For Barrett's esophagus, you use the Prague CNM criteria. And also for bleeding ulcers, you use the Forest classifications. So these have to be incorporated into your reporting system because they have the significance. Another area is the systematic biopsy protocols, this Seattle protocol for the Barrett's esophagus. These are some of the priority indicators which have been identified, and they promote high value care in upper GI endoscopy. So, what are the steps for a high quality upper GI endoscopy? As we already discussed, prior to the procedure, you get the consent, you do a proper patient assessment, and you also pre-medicate the patient with defoaming agents. During the procedure, you have to spend sufficient time for the procedure. And for an upper GI endoscopy, the minimum recommended time is around 7 minutes. And a photo documentation, ASGE recommends around 10 images. And the use of image enhancing techniques like NBI can also help in specific cases, and also following the various biopsy protocols. So, simethicone as well as N-acetyl cysteine prior to an endoscopy can help you inspect properly during an upper GI endoscopy. And this is the photo documentation. You are supposed to document the following 10 sites from the proximal esophagus, distal esophagus, the OGJ, and coming to the duodenal bulb, second part of the duodenum, antrum, cardia, fundus in full inversion, lesser curvature and corpus in partial inversion, incisura in partial inversion, and greater curvature of corpus in forward viewing. Coming to Barrett's esophagus, you are supposed to have a good documentation of the squamocolumnar junction, the gastroesophageal junction, and the diaphragmatic hiatus. And you diagnose Barrett's based on the extent of columnar mucosa. It should be more than 1 centimeter, and you're supposed to classify using the Prague CMN criteria. During surveillance, you use the Seattle protocol, in which you take a 4-quadrant biopsy every 2 centimeters, and minimum of around 6 biopsies have to be taken, because this Seattle protocol improves the dysplasia detection by at least 2-fold. So this slide is about the systematic screening protocol for gastric biopsies in gastric pre-malignant conditions. You take biopsies from various sites in the stomach, put them in 2 jars, the antral biopsies in jar A and the corporal biopsies in jar B. Coming to GI bleeds, the Forest classification has to be applied, and hemostasis has to be documented. You always use at least a combination therapy for achieving hemostasis, especially for high risk stigmata, for lesions with high stigmata of bleeding, and this has to be adhered in more than 90% of the cases. Coming to the next area is colonoscopy. Colonoscopy, as we all know, is a cornerstone of cancer CRC reduction worldwide. It's commonly used for CRC screening, and it's been the first and preferred colorectal imaging test in patients with presenting with symptoms or patients at high risk for CA, with especially patients with a strong family history or IBD. The 2024 ACG and ASG Quality Task Force updated the previous guidelines from 2006 and 2015. There are certain core quality indicators and certain newer indicators which have been formulated. The set of priority indicators in the latest update is about the adenoma detection rate, which has to be more than 35%. I'll be discussing about the SSL detection rates more than 6%, that is the sessile serrated lesions. Bowel preparation adequacy has been a newly highlighted thing as a priority indicator, reflecting the growing evidence of serrated lesions contributing to the CRC reduction. Cecal intubation rates was there all along and still remains as a core quality indicator. And newer things like the surveillance intervals and adherence have been also been modified. So coming to the ADR, that is the adenoma detection rate, it's the most clinically relevant and the best validated quality indicator in colonoscopy. It remains the strongest validated predictor of protection against colorectal cancer. From the previous guideline, they have decreased the age of screening from 50 years to 45 years, and indicated ADR in screening, surveillance, and diagnostic non-fecal test positive patients, and they've excluded patients with positive fecal test, IBD, and known cancer. ADR at least a minimum of 35% is what is recommended. Most centers have a good ADR proficiency of around 40%. And this funnel thing actually illustrates between the endoscopic variability. As the procedure volume increases, the variability narrows. Why sessile serrated lesions, especially when you already have an ADR? This is because some endoscopists may have an ADR more than 25% but still have a low serrated polyp detection rates. And serrated polyp detections has been shown independently to predict the risk of post-colonoscopic colorectal cancer. So as you can see, the higher the rate of SSLDR, the colorectal cancer risk decreases. This means ADR alone is insufficient to fully assess cancer prevention quality. And now more emphasis is being laid on bowel preparation adequacy. You expect a target of more than 90% when it comes to bowel preparation adequacy. The commonly used preparation scores are the Boston bowel preparation scale, in which you need a score of more than 2 in all the segments. Inadequate bowel preparation not only adds to the cost but can indirectly increase the PCCRC risk. Always repeat your colonoscopies within 1 year if your bowel preparation is inadequate. Coming to withdrawal measure is basically a process measure. It's not a substitute for detection rates. You have to spend at least more than 8 minutes in normal colonoscopy, excluding the time taken for your biopsies or other interventions. Optimized technique includes systematic examination of the mucosa behind the folds, valves, or the flexures, and you have to thoroughly clean the do a thorough intraprocedural cleansing before you complete your inspection. The quality indicator here is when somebody has a low adenoma detection rate along with a short withdrawal time, then it likely means that the inspection technique was inadequate. Coming to the resection quality indicators, the various guidelines have formulated certain specific indicators with respect to the lesion size, also the lesion shape and the location. You have to use a snare to document the size of the lesion. For lesions more than 1 centimeter, you can use a snare, or lesions less than 1 centimeter, you can use a snare sheath. Always document the location because it helps in surveillance post your resection. You can also follow these patients based on the location. The morphology of the lesion has to be identified by the Paris classification. And during resection, you have supposed to document the method of resection. what are you actually doing to resect the tumor, the polyp? Is it cold forceps or cold snaring, hot snaring, EMR, or you have to specify the methodology and also the complete resection confirmation. A high percentage of patients, like my previous speaker told, less than 1 centimeter are now easily done by cold snaring, which decreases the post-procedural complications as well. High quality colonoscopy is not about performing the procedure well, but it also requires strict adherence to the evidence-based screening and surveillance intervals. For example, the US Multi-Society Task Force on Colorectal Cancer, they have given the detailed recommendations for follow-up of patients after colonoscopy and polypectomy. This is mainly done to avoid overuse because it creates another burden as well as cost issues, and in order to not use avoid under surveillance as well, because it will indirectly increase the CRC risk. What I would recommend is every unit should have this screening surveillance interval stuck on, so that you can follow up with your patients during the discharge plan itself. Serious adverse events are quite rare in colonoscopies. Most of the complications are very minor, very small. In diagnostic colonoscopies, the bleeding and perforation rates are also quite small. The other non-serious side effects are mainly cardiopulmonary events, which you should be documenting in your post-procedure reports. Coming to the next therapeutic intervention, that is ERCP. ERCP is a primary therapeutic intervention for biliary and pancreatic diseases. Why does ERCP need strict quality control? As you can see here in the graph, that it is one of the procedures with the major complication rates of up to 5%, which is mainly post-ERCP pancreatitis. Numerous studies have shown that ERCP quality varies significantly between providers and centers, and the procedure success as well as the adverse events are closely associated with the unit and the endoscopy volume. Like in other indicators, again the ERCP quality indicators, you have different indicators, but mainly the priority indicators are you should have a proper documentation. You should have a deep cannulation of the normal papilla. It should be more than 90%, and success of stone extraction in extrahepatic biliary stone should be more than 90%. And the current recommendations for NSAIDs is that it should be used in more than 90% of the targeted NSAID prophylaxis should be more than 90%. Another global outcome metric is the unplanned hospital visit post discharge 30 days should be less than 50%. Here you can see that the multiple RCTs and meta-analysis have shown a relative risk reduction of around 50% in post-ERCP pancreatitis when rectal NSAIDs, indomethacin or diclofenac is used. Strong evidence now recommends pre-procedural administration, and the current guidelines say that in all the ERCPs with the native papilla, you are supposed to give the rectal NSAIDs prior to the procedure. And the placement of prophylactic pancreatic stenting, especially in high-risk procedures which involve the pancreatic duct, or when you use the inadvertent pancreatic duct cannulation, you should supplement with a PD stenting. A particularly meaningful and patient-centered sequela is an unplanned hospital visit, 30-day hospital visit. This is a global outcome metric because it captures the specific ERCP related complications like post-ERCP pancreatitis, bleeding or perforation, cholangitis, also other physician related variables with pertaining to an ERCP, and it is preferable to the outcome measure should be less than 15%. US is another most interesting area which has come to the forefront, and specifically interventional US has grown exponentially in the last decade. From diagnosis, you have moved on to the various drainage procedures, ERCPs, Rendo techniques, and it has branched so much. Like the previous interventional procedures, the latest ASG task force update shows the newer quality indicators for EUS. The priority indicators for EUS is that you have to have an appropriate indication, which is common for most of these things. The diagnostic adequacy of FNA for the pancreatic lesion should be more than 87%, and it also the other priority indicators are technical success targets for drainage and adverse events monitoring. The EUS diagnostic adequacy indicator, this basically indicates the frequency with which EUS guided sampling obtains a diagnostic specimen from a malignant pancreatic mass. And various studies have shown that the adequacy has to be more than 87%. FNA or FNB both are almost comparable. FNA, especially when it is when you do it along with a rapid on-site examination, is as good as an FNB. You don't have to do an FNB all the time. Also, when it comes to using the type of needles or the size, 22 gauge or 25 gauge, these are both equally comparable, although some studies have shown 25 gauge needles to be better. Coming to interventional US LAMS, that is the lumen opposing metal stents, these have revolutionized the therapeutic US. Various US guided drainage procedures like pancreatic fluid collections or the gallbladder drainage or the biliary drainage have been developed, and these have different success rates. Success rates should be around more than 85 to 92%. Performance targets for these newer things are intentionally kept low because the majority of these procedures are done in expert centers. This table actually shows the various complication rates for the diagnostic and the interventional US, and the performance targets for the diagnostic procedures when it comes to perforation, infection and bleeding, pancreatitis should be less than 1% for diagnostic procedures, and for interventional procedures it ranges from around 10 to 25%. So what are the key global philosophies when it comes to these different quality indicators? Before we dive into the metrics, you have the American-based guidelines, which is predominantly outcome-driven. They are worried about the numerous various benchmarks, and it's all oriented with the outcomes. Whereas the European system is basically, they have structured performance measures, and they focus mainly on the inspection quality. Whereas when it comes to the eastern part, our counterparts, the Japanese, they have a very meticulous system examination, and their focus is mainly on the early cancer detection. So when it comes to the various quality indicators, there will be mild variations, almost different styles, but all these guidelines have one particular goal, that is to improve the outcome of the patient. So what about our perspective when it comes to the Indian data? In India, endoscopy practice basically exists in two parallel worlds. On one extreme, you have the very high sophisticated centers where you have high-end equipments and gadgets, and on the other end, you have resource-limited endoscopic centers. Often you can find both these things within the same city. The documentation systems also vary from the very high sophisticated centers to handwritten, registered in some of the government hospitals. Our disease burden is particularly different. We have a large volume of the upper GI disease, and most of our patients present with late stage cancers. And now with the introduction and rapid growth of these endoscopic services in Tier 2 and Tier 3 city, you go to any village in inside Tamil Nadu also, you will find one gastroenterologist with the latest advanced machines. So, the challenge for us is very clear. We need to develop quality metrics not only based on the Western quality data, but we need to take our own practice into account when we start developing these quality metrics. Encouragingly, our ecosystem is evolving. We have at the system level the NABH accreditation, which has strengthened the patient's safety, infection control and documentation culture, and also the audit cultures. Our insurance schemes are now more commonly, increasingly linking their empanelment to the quality standards as per the hospitals, and the growing digitalization also enables endoscopy reporting and auditory trails. On a professional level, now we started moving slowly. Our training programs are slowly starting moving towards competency-based assessment programs, And many centers are now adopting the global indicators for the easier things which can be incorporated as the cecal intubation rates or the ADR. And you are supposed to do an audit, re-audit from based on your own performance and fixed timelines. What I would suggest is for every Indian endoscopy unit, first we can measure the number of volume of cases what we do and the indication appropriateness. Are we doing the right procedures for the right reasons? Secondly, we can delve into the technical quality parametrics, like the things which we can which we discuss, like the priority indicators like ADR or cecal intubation rates or bowel preparation adequacy. These parameters can be incorporated into our practice. And then third, we should maintain a transparent complication register, be it bleeding or perforation or post-ERCP pancreatitis. It all come into documentation. And fourth, the report quality. Every one of us should strive to take the photo documentation and have a standardized template for reporting, and try to correlate these our reports with the pathological correlation. And finally, you should always take feedbacks from our patients on the quality of procedures which we have done. Not try to incorporate all the quality indicators into our standard generalized practice. It is wise to audit your own, not monthly audit. I would say is bit difficult given our time constraints. At least 3 monthly or a 6 monthly audit of our procedures, and then fall back into the loop. You audit, you revise your performance stats, and then again re-audit. So this can be done. And looking ahead, several changes are likely because AI is coming a big way, which will help in lesion detection during our procedures, and it will also be helpful in quality feedback. We might soon start having national registries and benchmark networking based on our own priority indicators which we develop, which will be a factor linked to reimbursement, outcome-based reimbursement or accreditation expansion based on what outcome indicators we strive to improve. So if we get this right, India still has the opportunity to develop a scalable, cost-effective quality model that would serve as a template for other emerging healthcare systems. So the key here is not whether we can implement these quality indicators, but how intelligently and sustainably we do it. Quality indicators do not definitely make our endoscopy slower, they make excellence reproducible. These are my references. Thank you.
Very nice lecture, Dr. Raghvendra. Just wanted to know if you came across any articles on Indian quality indicators by any society, any study? Because when I searched like you for
in Hyderabad, AAG Hyderabad has one. They are in the process of developing, and also we recently had one NBA session, ma'am. They are into developing these quality indicators for our own population. It's still in a very nascent stage.
Especially when it comes to resource limited setting, all the points. Having high quality scopes and like Sangameswaran was telling about using less contrast and then use more of image enhanced endoscopes and digitalizing everything. So we all know from a government sector it's not that easy for us to.
Anyway, we are not using any contrast.
Sir?
Is there anybody using contrast, liquid contrast?
No, in general, sir. Apart from documentation, so all these things and then time taken for completing a procedure. So these things have to be overcome, and then probably we need to, if we want to improve the standards and to attain the global standards. Like 7 minutes in upper GI, 8 minutes lower GI.
Maybe this should be a compulsory part of the teaching curriculum. We just talk about it as lectures during some part of classes. I think it will be a very valuable tool to have this as a compulsory part of the teaching curriculum. At least reports which come out in future will be more standardized. We have a very heterogeneous population performing endoscopic procedures, non-gastroenterologists as well. So I think that should be included as a formal part.
As Madam said, sir, catch them young, train them younger. So when something gets incorporated into our PG curriculum, maybe we will slowly have improvement in the.
Sir, one more comment. I mean, probably when we had a last meeting, yes program that's organized by Dr. Malay Sharma and Dr. Ravi sir was there, we had a discussion with the young, upcoming gastroenterologists so that they can ask any question to Malay or Dr. Ravi. One question was thrown up is, sir, can society restrict that the thing, now everyone is doing endoscopy, so can society restrict that these are qualified people, so they can only do endoscopy, even surgeons and sub-technicians also doing endoscopy. So when Malay came with the answer that, no, we cannot stop, MBBS candidate can do a endoscopy. He learns endoscopy and he can do an endoscopy. Probably society can come up with the guidelines that you can do an endoscopy, but it should be of a basic norm. You have to have 22 pictures of all the areas, like reporting should be good. So that in way that the quality of endoscopy will be better, we can pick more cases.
Basic question is our endoscopy training perfect? At the examination, you examine the clinical and theory. Are you examining their endoscopic skills? Then what is the question about this? There are some people come, somebody gives a 2 weeks training and then he is an endoscopy.
Even in our setup, the pre-procedural, I'm sure, because the case will be seen, that's what I tell all our PGs, the person who does the endoscopy will not be aware of the thing. So, right from starting from indications, are we doing the rightly doing the procedure, so process should start from there.
We have this type of neurosurgery. They are supposed to do surgery in front of the exam. That because of patient safety, they report a
This topic was brought in mainly to see where we stand. Can we start off with something what is achievable across, like pre-procedure consent forms? Are we, maybe indications can always be contested, but at least are we consenting them regularly? Can that be monitored? I mean, even in government setups, that is not going to cost much. It can be it's not resource dependent. Some of them are not resource dependent. So at least some place where we start. As he said, it's not going to be a one-time thing. We have to audit, and there should be a place for auditing in an anonymous matter. I mean, that is where the problem comes. Once the name comes out, then people feel very defensive about putting up as an audit.
Exactly, sir.
Yeah, the consent. Informed consent can have a video consent, or especially for difficult persons, not like high risk persons, like US and all. We do for people, all the patients, they will put the chin up, they are looking like a there's a trauma, they will not have a want to, they will know the case. Just video consent, you do surgery, liver transplant, we also do video consent. You do any sport. That is important, major important.
Do any of the corporate do practice quality indicators? Do you have in Apollo? We have quality indicators like complication rate and turnaround time. I mean, just for namesake, at least for an ABH.
Probably in department as such, probably we don't specifically look for, but there are quality benchmarks. There is a quality department which looks into it. So
we do
that's
have.
what quality department has it, which specifically looks, and there are
We have
I think
three
quality
post
indicators.
TRCP pancreatitis and effectiveness of GI bleed management.
So that
Both
is
of
left,
them are
that is left
quality
to the
indicators
department
for
to
us.
decide. So
Yeah,
we don't have,
we
but
two indicators.
there are separate quality departments because we have this JCI, NABH audit. So they have certain things which happens in the background. We don't even come to know about that data that they collect.
We at Cancer Institute, we are maintaining at almost 50 to 60% of that. We maintain a register. We take proper consent before doing all endoscopy procedures. After that, we maintain a long register in the endoscopy room. In that, we after mentioning the patient particulars, what is the in time, out time, whether it is all these complications, what is the pulse and BP, SpO2 at the time of entering into the theatre, then what is the pulse BP, same parameters exiting. All these parameters we are maintaining for the past 2 years in our institute.
I think that will be done most of the.
We applied for a accreditation for a endosafe in Apollo Proton. So there is only OGD and colonoscopy. They have a register, and we created some more deficiency which were told by the evaluator. We additionally created. Same thing we are trying to implement in the current My Place. In fact, your in and out time, we have a separate column for scope in and scope out time. So in addition to patient in and out, that is there always. So now we have a column which says when do you go in, or have you done endoscopy for 7-10 minutes. So that we are measuring it now, the new register has.
We have to have at least an understanding. Wherever feasible, you can maintain the quality, like getting all the data. But you should have a quality indicator. It's not everything. At least few, like say complication rates or like missing something, missing a lesion or something should be there in a department wherever feasible. In government setup, with their resource limited settings, they can have their own quality indicators. I think that's how we can improve the quality of endoscopies, and probably the younger generation, they will learn from their beginning.
In fact, in our department, if any complication happens, we make it a point to document it and then get it out.
But we have to have a register, sir. This is how quality indicators work. In our department, we have a quality indicators. We culture the scopes every month, and we maintain a register saying that, and we maintain a register saying that this much operations have happened, something like zero, whatever it is. You have to have a register for that. That is how quality indicators has to be documented.
People win the case. So especially for the pre-procedure, post-procedure, and same day discharge, everything is taken into account in small suits. So this is all taken into account. It's not routinely going, it's a quality indicators good. This is going to affect your future also. It will affect our purse and our profession also.
Then we'll, I think it's maybe Tirumurthy.
This, whatever the quality indicators, this is not a big task. We can have a small group or committee, we can prepare what are all the requirements for the this thing, quality indicators, can be vetted by all the senior members in the society, and can be used by all the, at least by the gastroenterologists in Tamil Nadu. This is not a big task, it can be easily made with a group of doctors in few months period.
Thank you, Dr. Raghavendra.
Thank you,
So
sir.
you have generated so much of discussion. Now we'll move on to the next speaker, endosuturing, current status and application from Dr. Vinod Kumar, consultant GE from GEM Hospitals.
Good evening, everyone. At the outset, I'd like to thank Dr. Parama sir and TNISG for giving me this opportunity. Dr. Parama sir has asked me to speak for 25 minutes, but my table mates have instructed me to talk only for 12 to 15 minutes since it's dinner time. So I restrict my talk to 15 minutes. So this is an exciting topic given to me, endosuturing, current status and applications. I bring greetings from GEM Hospital, Chennai. So I split my talk into three things. One is, what is the need for this endosuturing? We already have some robust closure devices. What is the need for this endosuturing devices? Second, what are the devices available at present in India? And third, and how are we using it? What does the evidence says? Let's go one by one. We all know like therapeutic endoscopy is coming up in a big way. Previously, what we have not thought about is we are doing it now. For example, exposed full thickness resection device, full thickness resection. 10 years back, if someone tells me that you will be removing extended gist from the peritoneal attachment, nobody will believe it. Because we are removing it because of these devices. We have these robust closing devices, we have this hemoclips, endo loop applicator, and then mantis, extract, endostitch. Because of the devices, we are clearly going into the peritoneum, dissecting like a surgeon and bringing out the tumor. We all know EMR, endoscopic mucosal resection. it carries almost 1 to 2% of perforation rate if it's a laterally spreading tumor, whereas ESD carries 4 to 7% in a colonic tumor. And what are the indications of our closure? When we do an ESD, when there is an unclear depth, we usually close the defect. When there is a target sign, that means a breach of serosa, we put a clip and close it. And last is a full thickness perforation. If we see, we used to close it. Previously, we are worried about the perforation. Now we perforate, we do a resection, and we close with the robust closure devices. We have some good closure devices like through the scope clips, which are like even 1.62 centimeter clips are available. OTSC clips. Still, we do need this suturing device. The answer is yes, because this OTSC and TTSC are not full thickness closure devices, whereas the suturing devices like Apollo EndoStitch is a full thickness closure device. So to close large defects, not amenable to close any other devices, we need these endo suturing devices, and it causes carries a transmural closure. The current options available are these three devices. One is overstitch device, second is extract suturing system, and third is an endoscopic hand suturing. I have experience with the first two, overstitch and extract, not enough experience with endoscopic hand suturing, and this looks like an exciting prospect. I don't know affiliations with Boston, so these two are from Boston. Since the topic is given to me, it's owned by Boston. First, we'll go see one by one, which is extract. We know what is extract. That's through the scope suturing device where they use a extract like system. I'll show you. These are the tags. These are the helical tags. What they do is they screw into the mucosa adjacent to the leaks. So it enters into the submucosa. Probably it can pierce a muscle and creates an anchor-like thing, and then you release the suture. At one thing, 4 tags are released, and then we close it, and then we fasten it, and we approximate with this cinch, and then we apply it. It's a small video which we have done for a esophageal fistulous closure, and this doesn't cause a full thickness closure. It's only a partial thickness closure, so we have to use this in appropriate situation. If you are using in a gastric station where the mucosa is thick and the muscle is thick, you cannot apply a full thickness closure. It can be used in esophagus or duodenum. You can see the fistulous site there. Here, like probably you can use an overstitch also, but no other devices I don't think will approximate this. Ideally, a APC has to be applied. So to create a raw area, so that if you approximate, it will heal on its own. So after applying the APC on the edges, we use these extract devices. I already shown in the first figure how to apply this extract. So it's nothing but through the scope, push this in, and then the assistant will torque you. So it gives a spiral thing. So you can see the first tack was applied downstairs, and then you create a zigzag pattern so that the entire defect will be closed. It's a single suture. So the tack was released now. And you go and apply the second tack. Sir? They try to suture the suture, surgical. No, he has seen a suture. He is asking what is the foreign body inside the hole. Yeah. Yeah. So you apply 4 tags, and then you cinch it and you release it. So it's not finally closed. Once you apply the 4 tags, and then you can pull it off so that everything will approximate. And then you cinch it. Cinching is nothing but tightening the sutures. You can see how beautifully it has closed. Even like at present the patient is doing fine. There is no leak there. So the advantage is less demanding. Since we need not exchange the scope, we can do with the conventional endoscope. It's through the scope, and it's more cost effective than overstitch devices. But the limitations are it doesn't give a full thickness closure and need for adjoint clips in some cases. The next is the overstitch system, which I think is a game changer. Like it's intended for endoscopic placement of sutures and approximation of tissues. When there is a leak, for stent fixation, you apply it like a surgeon. And this is the basic, components of an overstitch. We see the anchor and an anchor exchanging device and the suture. You can see the helix. I'll show you a video how exactly it operates, and there is a handle which is attached to the tip. You can see it here. This is a handle by which the endoscopist open and close the needle holder. So the needle will be exchanged here with the suture. And for introducing in, we need a over tube. First, we have to do a regular endoscope, place this over tube into the mid of the esophagus, and you take this whole system into the overstitch. And this is a small video. So after placing the over tube, you go to the site where the leak or suture, fistula is. This is how it exchanges the suture with the needle. There are certain steps you have to do for this suture transfer. Once the suture is transferred there, you take the whole assembly into the area of interest and put a helix, grasp the mucosa inside the mount. This causes a full thickness. If the mucosa is not easily coming out, just release the helix so that you should not catch any structures outside the peritoneum, and then you pull it. So once you pull it, you will suture it back. So the same thing, it has to be repeated. And finally, you have to cinch it. See, by cinching it, you approximate, you pressurize, and both the edges will come closer, and then you release it. Finally, it looks like this. I have a video to show this, probably. So if you look at the laparoscopic thing, you can see the suture outside the gastric mucosa. So it shows this is a full thickness bite, not a partial thickness bite. This is the advantage of overstitch. And the last modality of our interest is endoscopic hand suturing. Is a new technique for the closure of mucosal defects in the GI tract. I got this video from Video GI. I have not used it personally, but it looks very, it has very big potential, and it uses a monofilament absorbable thread with tapered tip semicircle needle, what they use it in laparoscopy. And by twisting the instrument or manipulating the endoscopic tip, we suture it like a surgeon, and sutures are tightened and remaining thread is cut with a loop cutter. And the main advantage is the strength of the sutures are more higher than conventional endostitch and other things. But the limitation is data is lacking, and a long procedure time is needed. I'll just show you the video. Okay. First do a APC, create the surface raw, and then introduce the system through a over tube. It's nothing but it contains a needle holder and the needle. So this is how you take the needle holder with the needle inside the over tube. And then you go to the area of interest. This is the needle. Needle will be a semicircle needle. So if you take a bite, it goes through the wall and come out of the wall easily. So by twisting the equipment, it's like a surgeon or a hand sieving. By twisting the equipment, you can put a suture on one end and take a suture on another end. Various suture can be taken. You can put an interrupted suture, figure of 8 suture, or a running suture. There are some studies which shows that the median suture time is almost 4 minutes, and they have completed the procedure in 40 to 50 minutes. So you can see the semicircle needle coming out, and then they caught hold of the pointed sharp edges, and then they pull it off. So by doing an running suture, they close the defect. And once you are done, it will be tightened and it will be cut with a loop cutter. and they immediately they inject the contrast and see to see for any leak. It has not extravasated. So this is a study which I am talking about. This is from Germany. They have used almost EHS, endoscopic hand suturing device, for 19 patients, and almost the technical success rate is 78%. And if you look at it, the median time is almost 3 minutes for a single suture. So it's an upcoming good evolving technique. Probably many trials and studies are needed to apply it in India. So coming to the indications, these are the 3 devices, and where it was all indicated suturing device, and one is the stent fixation. We know this covered stems is used for biliary, esophageal strictures, for leaks and things. The major disadvantage of covered stems is this migration. At present we have something called stent fix, but studies have shown it's better than stent fix. In Western countries they are using it over stitch for this as a stent fixator. And it's better than conventional hemoclips or even probably OTSC stent fix, and for fixing a flaps before an edge procedure. And we already spoke about this ESD and EMR closure, fistula and leak closure. We are using Apollo endo stitch devices, and the most important indication for an Apollo overstitch is endobariatrics, where we do at present we have done some endoscopic sleeve gastroplasty or a revision bariatric surgery post and transoral reduction after a bariatrics surgery, TOR. This is one of our videos which we have done recently, which I will like to share you for this endobariatrics. Like we have done an ESG and see how it works. It was done in our institute for an BMI of almost 37 patient. We have done this. First we inspect the mucosa to see the mucosa how it looks like, and then we start the area of from the incisura. This is a device, the same thing which you have seen in the animated video. We catch with the helix, we pull off the mucosa, and then we apply a full thickness suture. Like that, you apply the suture from one anterior wall to posterior wall, and then come back to same place in a U-shaped manner, and then cinch it. By doing this, we create the small pocket of the stomach. The stomach capacity will be reduced. The patient will lose weight by delayed gastric emptying. So you can see how we are reducing this stomach space. You can see how beautifully it has been reduced. This patient, we have applied 5 sutures to reduce its stomach capacity. So, for the want of time, I will forward this video. Vishnu, is it okay? Okay. And then you finally cinch it so that the stomach capacity is raised. This is the final video which we are showing after the ESG. It does look like a very small stomach, but believe us, the patient doesn't have any GO or symptoms, and the patient is doing well. This is antrum which is free of this reduction. And one more interesting article I found during this presentation. In Western countries they have used this overstitch for poem closure. Still have a belief like after a poem whether we need to close it with even clips or not, because once we come after 1 day or so, it's very difficult to get into the tunnel. So what my personal feeling is, like, even endo clip will do more than a good job, but they have used overstitch. They have compared both. They found out that except for the there is no leak, same thing. The length of stay is decreased. Again, cost does matter in India. The cost of a hemoclips is very low compared to an overstitch device. Again, probably once the sutures and all these equipments are coming for a lesser price, we can use this for multiple things. So when to use this: over the scope suturing device, through the scope suturing device, and endoscopic hand fixing. Over the scope suturing device, it can be used for a very large defect, and through the scope it's for a smaller, not for a smaller defect, for a large defect. Very large defect, you use this overstitch, and big, medium cases you use as through the scope extract like thing, and endoscopic hand suturing for a large defects. The major disadvantage is the cost with all these devices. Probably Apollo endo stitch, each suture will be costing around, if you get the handle, it will be costing around 1.8 lakhs. For a single suture is 17,000 MRP, and for a cinch is 33,000. So if you want to put a single suture, you have to give at least 2.5 lakhs. If you are using a 5 suture, it's almost 3.5 lakhs. Cost is a major burden for this suturing device. That's why we are not using for a simple fistula closure or leaks or a stent fixator. But we know once the competition comes in, all these things will come down. Probably if it is available for 15,000 or 20,000, probably the best device to use. And this is the data from US. They are using this endoscopic suturing device for all this indication. For most of them are using it for fistula, and most important thing is they are using it for RYGB revision. That is for a TOR procedure. You are using this for 24%. ESG is not in a big way, but TOR is coming up in a big way in Western countries. Thank you for your patient listening.
There are variants of which have better. If we go back to suturing clothes, there are variants of which have better medicine. After everything goes back to the same.
Thank you, Dr. Vinod, for it looked like a fantasy film. Anyway, I'm sure things will happen in the future. Thank you for a good presentation. So with this, I think the session is over. Thank all the speakers, Dr. Sangamesh, Dr. Raghavendra and Dr. Vinod for their excellent talk. Thank you. Over to Dr. Arul now for the formalities.
Thank you, sir. Thank you, chairpersons. And I believe we'll all agree that we had a wonderful evening today. And I'd like to thank the patron, the office bearers of Tamil Nadu ISG for this meeting. And special thanks to Dr. Ilarasi and the postgraduates who had an excellent approach to chronic diarrhea, which was very useful for everyone. Dr. Karthikeyan for his journal review. And special thanks to Sangameshwar and Raghavendra who had very unique presentations which created a lot of thought process. We appreciate both of you and excellent videos and talk by Dr. Vinod. And thanks Solaris and Residency Towers for providing the facility and this evening. So we'll proceed for the cocktail dinner. I'll request Solaris people just to have a word before we part for our dinner. Thank you. We'll meet next month, last Saturday, as usual. Thank you.
First of all, my sincere thanks to Tamil Nadu ISG as well as Professor Dr. Ravi and Dr. Pramanayakam for giving the opportunity for this great gathering on behalf of Solaris Healthcare. Thank you so much. Actually, the Solaris Healthcare is a fast-growing company, a pharmaceutical company. They are very much strong in the ENT. Now we entered into the MGE, gastro this also. Thanks for the opportunity, Doctor. Thanks on behalf of Solaris Healthcare. Good day. Let us join for the dinner.